Yeah, I have another question, Bill. Who do you benefit from radiotherapy in terms of the treatment of rectal cancer?
Probably the most important are the patients where the potential surgical margin, usually the perimesorectal plane, is being threatened or actually penetrated by the outer tentacles of the cancer. And what understanding we have of exactly what radiation or chemoradiation does to a cancer suggests that the outer tentacles of the tumor tend to be drawn back within the envelope. So what we seek to achieve really with radiation and chemoradiation is a regression of the outer part of the tumor away from the plane that the surgeon is likely to cut through. Of course, the surgeon can also be helped to take an adjacent organ because the MRI perhaps shows actual invasion or that an organ is in contact with the cancer, and to some extent MRI can be a route map. Anyway, the answer to your question, I believe, is mainly the threatened margin, and that's why Phil Quirk's ultimate analysis of what we produce is so important. We want to avoid margin involvement. If we've got a situation where margin involvement seems inevitable, then radiation is logical. It's also become standard practice for very advanced tumor within the mesorectal envelope, even if the margin looks clear. The scientific basis for that's a little less solid, but it is understandable in cancer when you're in a bad risk group that all the available weapons might be fired, and we know that radiation is better given before surgery than after.
What about the lymph node metastasis? There are some centers giving radiotherapy for if they detect lymph nodes.
Yeah, well,
there is no threatening margins.
Well, I must confess that Brendan Moran and I and quite a number of my friends and fellow travellers in surgery rather think that the surgeon can deal with the lymph nodes adequately, and that an involved lymph node should not necessarily be an indication for radiation or chemoradiation. In fact, in our Mercury study from the Pelican Center, it is interesting that extramural vascular invasion, something which Phil will talk to you about, is actually really quite a lot more important marker of a bad prognosis, and therefore perhaps a more reliable indicator for giving preoperative adjuvant, neoadjuvant treatment than the involvement of a small number of lymph nodes, which probably make less difference to the outlook than extramural vascular invasion. In many ways that makes sense, because we know that ultimately most people, if the initial surgery is good, most people who do die of bowel cancer, and that's still a lot of people, die of metastases. So I would say very bad intramesorectal disease, but most importantly threatened or invaded margins. What do you think, Phil?
I think certainly neoadjuvant therapy is very good for downstaging tumours and moving the tumour edge away from the surgical resection margin. And we've got good evidence now that if you have an involved margin after neoadjuvant therapy, that is a very bad sign for local recurrence for the patient. I think I'd also agree that there is a place for neoadjuvant therapy in those patients who have bad intramesorectal disease, and you should consider what you want to do when people are having an abdominoperineal excision. That neoadjuvant therapy has been shown to be very good at reducing local recurrence, but short course radiotherapy has not yet shown to improve overall survival. So it's good for local recurrence, but we need other things to come forward for improving overall survival. And really, we do know that best surgery has a big impact, because if you do high quality surgery without radiotherapy, you will have much lower local recurrence rates. And if you do very high quality surgery and you have short course radiotherapy or neoadjuvant therapy, you can almost abolish local recurrence, making it a thing which is not going to be seen frequently in the future, which would be great.